Hi there. My name is Matthew Fuld, and I'm here with my colleague, Olivia Egan. We are very excited to be here with you today for our webinar regarding access to care. At Siemens Healthineers, our mantra is to pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. And to us, that really means having access to the right care. And in the webinar, we will focus on two aspects of access to care. Coronary CTA has proven to be a very reliable tool for guiding the treatment of disease, but you have to have access to it. And so we're delighted to have Dr. Todd Noce from Dartmouth University, who will discuss dual source CT everywhere with the SOMATOM Pro.Pulse, enabling greater access to care in the community. But access to care also means access to new levels of care. And with the introduction of photon counting CT in 2021, we have seen new abilities to see the disease that we all are trying to better understand with coronary CTA. And for that, it's my pleasure to have Dr. Ron Jacob from Wellspan, York Hospital, to talk about photon counting CT as a roadmap for PCI. Together, this will be a great discussion on various aspects of access to care. We will be available for questions with the physicians at the end of the webinar and are excited for you to join us. So with that, Dr. Noce, the floor is yours.
Good evening. My name is Todd Noce. I want to thank everyone for having me today. I am a radiologist at Dartmouth Hitchcock and will be presenting a topic of hospital-based imaging in the outpatient setting. Before we begin, I'd like to disclose that this is a paid talk by Siemens. So as we get started, I'd like to give a little bit of background of where I work and how the process of outpatient imaging with hospital-based equipment began. So the Dartmouth Health System, for those who are unaware, is a system that provides healthcare in the majority of the state of New Hampshire and parts of Vermont. And as we can see, we're known for the medical center and the medical school, but we're also made up of many smaller hospital networks throughout New Hampshire and Vermont. And we're going to focus today is where I work, which is the Dartmouth Clinics. The Dartmouth Health Clinics are organizations in Manchester, Nashua, Concord, or outpatient-based facilities, and started in the 1990s as outpatient facilities dealing mostly with primary care network. But as the healthcare market changed, so has the clinics. So over time, we became a multi-specialty clinic serving a patient population of 150,000 patients in Manchester, Nashua, and Concord, and more of an extension of the healthcare facility at the medical center. So offering patients opportunities in multi-specialty care, including the Children's Hospital at Dartmouth, the Dartmouth Cancer Society Center, and organizations such as adult and primary care and surgery, which includes all the subspecialties. So as the clinics change, so has imaging in these clinics. And so from a practice that went from 2 to 3 radiologists, we grew to a practice of 8 full-time radiologists with a budget of $175 million, performing 132,000 cases. And as our organization grew, so did all of the modalities that we serve, such as MRI, moving to 3 Tesla imaging, PET-CT, which includes Illuccix, dotatate imaging, a comprehensive breast services, and CT imaging, which will be the focus of this talk. So in looking to what we go from to invest into CT imaging, we need to look to see what the market has been doing. So there's been a strong push for outpatient imaging versus hospital-based imaging. This is a figure from 2020 showing that in 60% of the market was hospital-based at that time, but 40% growing was outpatient, representing approximately $20 billion of revenue. And it's important to see that the patients and the environment are pushing people to this outpatient setting. So the outpatient imaging needs to be on par with what is being offered in our hospital networks. So factors that influence the growth of outpatient imaging include policies and procedures in Medicare, cost of imaging, convenience, where can the patient go to get this done, and COVID dramatically changed the landscape of this, where patients were unable to go to hospitals or not willing to go to hospitals because of COVID and looking to go to outpatient centers. When we look at Medicare and private payers, there's different things that have occurred over the last 20 years that really affected this, such as changes in legislation, the Deficit Reduction Act in terms of reduced payments, bundling of codes for such as CT, the appropriateness criteria, streamlining what should be ordered, particular things like the neutral site payment policy, where there's a set charge, depending no matter where the images are being performed, and things like transparency rules, and no surprise that our patients are really in gear with what they're paying for their exams. So what this figure highlights that we've seen from 2007 to 2017, that most patients now have higher deductible health plans, that the Affordable Care Act has enrolled more and more patients in insurance, but more patients are paying things out of pocket, whether they have an HSA or don't. And what does that mean? What it means is the private payers are dictating sort of where the patient's going based on cost, and the patients are well aware how much that's going to cost them. So it definitely changes their prerogative of where to go. So on average, our patients are seeing that hospital imaging costs are more than their outpatient counterparts. That in our community, we can see exam prices varying by 70% for MRI and CT imaging, and as much as 200% for nuclear medicine imaging. So at Dartmouth, what we've done is created this strategy for investment where we encompass the ever-changing market for healthcare with outpatient imaging and invest in technologies to expand our services and to capture more of our patient marketing, which is where we started with the dual source 200 CT scanner. And so our current CAT scan program is 12,000 exams annually, and it continues to grow. And currently we have 2 fixed units that are greater than 10 years of age and a mobile unit. And we do perform CT fluoroscopy. This covers our majority of our patients and patients' needs, but there are older machines that limit our technology and limit our expansion of new services. And on the image on the right, this is Dr. Ledley, who created the first CT scanner to be used for healthcare imaging. And I could swear that the machines we currently had in practice were not much newer than the machine he's currently with. So when we looked at this idea of enhancing our CT imaging, we wanted to make sure we could continue to grow, get a decent part of the market share with expanded services such as cardiac imaging, provide benefits to services such as contrast optimization, which in 2023 with the contrast shortage, that was a big deal, with the limited use of contrast and the cost of contrast going up as a result of this, cognizant of radiation exposure, and dose to our patients as well. What are things that we face as barriers to this? How much does the new unit kind of cost us? Do we have the space and to put it in? Do we have to build a whole new space? Can our technologists perform the CTs that are with upgraded technology? As we all know, hiring technology is very difficult at this time. There's limited people, limited staff, especially in New Hampshire, a population that's not growing. Most of our technologists are homegrown, so we have to have a platform that they're able to use. How do we integrate this into our workflow? Are we able to do imaging, perform high-end imaging, but can we do it on the basis of maintaining our normal volumes where we don't have to stop our day and basically see a case and not want to read it because it's really slow, really cumbersome? Can our services be provided with software utilization that makes sense for us? Can we get recons that are consistent? Can we perform the studies on a consistent basis? So keeping that in mind, we did choose to go with the Pro.Pulse, which can see kind of fits all of our needs. Ideally, with dual source 2 energy, the cost of the unit was very high, traditionally speaking, and was a strong barrier. But this setup fits in a price point that fits our needs. Having an air-cooled system is a bigger difference than the other dual source 2 energy counterparts, which required a separate chilling system. And again, a workflow that allows us as radiologists, and more importantly, our technologists, to perform the exams at a basis that is reproducible, doesn't require a certain technologist being available, and continues to be more and more efficient. So as we know, the single source CT scanner, which we're all accustomed to, rotates at 180 degrees, and it's It takes 165 milliseconds to produce the image. But with the dual source dual energy scanner, we're able to do quarter turns, faster temporal resolution, better image quality at a quarter of that rotation. So what does that mean? It means we're able to get images of quality on fast-moving structures, scan patients without any heart rate, free breathing, no motion artifacts. We can alter the KV and MA, and that allows us to decrease radiation. It allows us to image monogenic energy to improve our contrast. And we're able to do more studies with morphologic and functional information at the higher speed, like the cardiac imaging. So in terms, what are we seeing this? How are we using this? So this week we began using our new scanner, which we did install, and we're already seeing optimization with the contrast using the monogenic plus. Our oncology patients benefit from evaluating lesions with 2 scans in one. So we were able to perform the non-contrast virtually. We're able to do the iodine maps to see if things are truly enhancing or not, which saves patients down the road from additional imaging on a potential cyst or lesion to see whether it enhances. We're able to reduce metal artifact, which more and more of our patients have our arthroplasties, whether they're shoulders or hips, which limit the evaluation, and see things on the fly that may be surprised, such as bone marrow edema and possibility of acute compression fractures. From the point of view of when we're looking for a new unit, our biggest limitation to some of our sites is how are we going to put it into the existing building? Is it possible? Well, the air-cooled gantry makes that possible. It doesn't require a separate chilling HVAC system. Takes up less space. The power requirement, so wiring the building is less of an issue. And it's nice that it uses less power from a cost from a daily operation. This is probably one of the most important things for us is how is the technologist going to able to use the machine? As radiologists, we're not the ones acquiring the images. We require a team of people to do it. We're very dependent on them. Experienced CT technologists are very valuable and very hard to come by. And as said previously, most of our technologists are joining our practice through internal promotion, former X-ray technologists, for example, training. But our schedule is getting busier and busier. So we want to make sure we have a platform that no matter who uses it, it can be performed accurately, reproduced quality images without having to change schedules depending on who's working. And the platform with the AI-based software is a key in that process. Things that are set up to help with the fast 3D camera and the fast 3D camera, allowing the patient to be centered in the machine, the unit to do the work to determine the parameters, the tablet-driven workflow, so that patients can have the technologist in room, which is particularly helpful for our CHAD or our pediatric patients. And again, using that artificial intelligence to help the process. And then having technologies in place, such as instant recons, and as we can see on the bottom, makes this very efficient for us. Less clicks, makes it easier, less screens to go through, makes it reproducible. And it's a system that we actually have had tried with our supervising CT technologists in the training process, who went down, trained on the machine, brought the information back, and spoke very highly of it. So one of the things that we're going to do now at Dartmouth is expand our cardiac imaging, something that was done mostly at the medical center. So now we're truly going to be in that extension of imaging services in the community to serve the southern part of the state. Things that we are going to do on a routine basis that can be done instantaneous with the setups that with this recon to go to was going to allow us for that calcium scoring. The recons that are going to be done on the fly, we're not going to be reliant on the 3D lab. It's not going to put the onus on the radiologist to do the 3D imaging, which is going to make us more efficient, make the images reproducible. This was a slide I remember during the presentation when we were looking at the machine. I'm like, wow, that's pretty impressive. 82% of people were able to perform a cardiac CT as a technologist on the first try. And when we first saw that number, we were sort of skeptical about that. And then again, we sent our supervising CT technologist to train, who is pretty hard-shelled, and she agreed it was really easy to do. And that this is a system that she can implement with her team to be successful. which is a really big deal for us. We, especially when we think of MRI, where we have certain technologists who are capable of doing exams better than other technologists. But that really makes a difficult schedule and makes it really hard for people with vacation availability. So having a service in place that provides imaging of this quality, these types of studies on a routine basis, without the need of having a certain technologist in-house, without the need of having the ability to access the 3D lab, is key for us. And having software in place that helps in the learning curve, that, as you can see, the Z-free, where you take out these little artifacts as a result of motion, smooth them out. No one's going to have difficulty reading these images. No one's going to question if this is an artifact or real. It's going to make the reads better quality, more reproducible. People feel more confident in what they're doing. So as a conclusion, this motto that we've developed at Dartmouth is this hospital-based imaging in the outpatient setting. The strategy includes keeping up with the services that keep up with the demand that our patient population is asking for, providing access to patients, making it convenient, improving our image quality, and continue to provide new services and programs within the system. The Pro.Pulse setup is definitely a setup that overcame the barriers which were hampering us from getting dual source to energy in the first place. Equipment that is at a price point that makes sense for us, an installation and construction project that isn't a barrier from us from doing it. And most importantly, the integration of this setup, having a setup in place from the technologist perspective and the radiologist perspective that enhances the workflow, not hampers it, improves efficiency, not delays it. So I want to thank you for this opportunity to speak at this conference. I really appreciate this, and best of luck in your endeavors.
My name is Ron Jacob. I'm the medical director for cardiovascular imaging at the Heart and Vascular Institute in Wellspan Health. Over the next 20 minutes, I'd like to take you over how we use photon counting CT as a roadmap for invasive angiography. So I thought we'd start with basics in terms of what we're trying to evaluate. Coronary angiography has been around for 50 years. As most of you know, angiography depicts a coronary anatomy as a planar two-dimensional silhouette of the lumen. So it's a luminogram. And vessel tortuosity, overlap, lumen shape can affect the interpretation of stenosis. And multiple publications have demonstrated that there's a discordance between the severity by luminal stenosis and the physiological effect of the lesion. CT has the unique capability of having a three-dimensional data set, and it's the newer modalities of newer scanners have very high resolution and gives you a comprehensive assessment of the coronary tree. So where are we with coronary CT? We start with Stefan Achenbach's seminal paper. That was the first foray into CT technology with EBCT in 1998. And it's interesting, in that paper, 124 segments had to be excluded for technical reasons. So we fast forward a few years later, we have slip ring technology with multiple detectors, improved spatial resolution, and better signal to noise. And 2008 was when the diagnostic accuracy of CT was established. Moving on to 2015, we had comparative effectiveness of CT compared to other modalities with the PROMISE study. And then in 2018, we have more of outcomes with SCOT-HEART. And then in 2022 and 2024, we're looking more at anatomy, physiology, CT-FFR, photon counting CT with ultra high resolution images. So, CT has grown rapidly over the last 20 years, and it has become a very effective and versatile tool. So what are we trying to look at? The coronary stenosis is not doesn't lend itself to simple geometric assumptions. If you look at this lesion here, it's complex, and depending on how you cut this lumen, you can underestimate the degree of stenosis. For example, if you take a plane like this, it looks like there really isn't severe stenosis. And the other issue is you have to have a normal segment. So when you have diffusely diseased segments, the normal segment sometimes is hard to determine. Once again, CT is helpful because you have a 3D data set. You can look at the length of the lesion, the cross-sectional aspect of the lesion, and you can try and ascertain where normal segments are. So this is a nice example where you see by IVUS, you see that post-stent, it looks like the stenosis has resolved, but most of the gain in lumen is due to the tear in the lumen here. Again, underscoring the complex nature of what we're trying to evaluate. So historically, cardiac catheterization has always been the gold standard, but let's look at it in comparison to CT, where we are now. So now the resolution we have with photon counting CT, we can go as low as 0.2 millimeters with high resolution, ultra high resolution imaging, with a base resolution of about 0.4 millimeters. CT has a 3D capability. The temporal resolution still lags behind coronary angiography at 66 milliseconds. With invasive angiography, you get IVUS. Now with CT, you can get a cross-sectional evaluation of the artery, which I'll show you later in some cases. With functional evaluation, we have both CT-FFR and CT perfusion. We have plaque volume and plaque characterization compared to OCT with invasive angiography. In addition, we also have evaluation of the LV mass, scar, ECV, and left ventricular ejection fraction with CT. And the radiation dose, especially with newer scanners, is comparable. It's around 1 to 6 millisieverts. So I'm going to segue into photon counting CT and how it works compared to traditional CT. So traditional CT, you have energy integrating detectors which convert X-ray photons to light and then to an electrical signal using photodiodes. This necessitates the use of septae, which you can see here, and reflectors, which reduce the geometric noise efficiency. So EIDs, traditional EIDs, cannot distinguish between high energy and low energy photons. It's just one bucket for the large part. Photon counting detectors directly convert X-ray photons into electrical signals with a high-speed semiconductor, which is converted into an electrical signal by an anode in the bottom of the semiconductor. This allows for discrimination of high energy and low energy photons, and that has clinical utility, as I will show you later. So what do you have or what do you need to image a small structure that moves during the cardiac cycle? So this is where photon counting has some advantages, dual source photon counting CT. So the first and most important thing is we need to freeze motion. It's like taking a photograph with a camera, right? You need a high frame rate to freeze motion when somebody is moving. So if your heart rate's less than 70 beats per minute, you roughly need about 250 milliseconds where you have no motion, where the motion of the coronary artery is less than about a millimeter. If the heart rate's above 100, you need a 150 millisecond area where you're able to capture this motion-free space. Now, the dual source photon counting CT has a temporal resolution of 66 milliseconds, which is faster than most other scanners because it takes advantage of the two detectors. The second thing you need is high spatial resolution. Keep in mind coronaries are between 1 and 4 millimeters, and you need isotropic voxels for 3D reconstruction. There's two modes, if you want to call it that. You have the ultra high resolution, which offers you a resolution of about 0.2 millimeters, and a non-UHR mode, which offers you a resolution of 0.4 millimeters. Remember, the smaller the vessel gets, the harder it may be to distinguish an area of stenosis if you don't have a good, adequate resolution to resolve the difference between 2 points. The third thing you need is a high contrast to noise ratio to resolve calcific plaque, non-calcified plaque, vessel wall, and lumen. Keep in mind, we have to separate these elements out to be able to clearly delineate the severity of stenosis. Towards this, you have tools with true spectral imaging. You can have images with pure lumen or pure calcium to separate iodine and calcium in heavily calcified lesions, and spectral imaging will allow for reconstruction at different KEVs to enhance contrast. Keep in mind that the closer you come to the K edge of iodine, which is around 33, the brighter contrast will appear. And in patients where you don't have enough contrast or there's soft tissue attenuation, that may be helpful to enhance the contrast in the lumen. In addition to this, there are kernels and iterative reconstruction to enhance vessel sharpness and to help with the assessment of stenosis severity. Now, what are some conventional barriers to coronary CTA? And I'm going to go over these in step by step. So obesity causes soft tissue attenuation, reduced signal to noise, and the ability to evaluate luminal stenosis. Heart rate, freezing motion. I've gone over this before. It's more challenging at higher heart rate, and you get a loss of sharpness in motion, again, reducing diagnostic certainty. Calcific plaque causes blooming artifacts, making the contrast within the lumen harder to interpret, and again, making the severity of stenosis more challenging to evaluate. Metal struts from stents can cause artifacts and reduce the accuracy, especially when you have small stents, less than 3 millimeters, with thick struts, greater than 1,000 microns. And radiation dose, of course, you're always trying to reduce dose and achieve as low as possible, dose as low as possible, while maintaining your image quality. And finally, renal insufficiency. Iodine dye, you're giving iodine dye, and you need diagnostic studies at lower contrast doses. So let's look at this, these factors. So this is a patient who was BMI of 60 with 460 pounds. They gave the patient 120 cc's of contrast, 7 cc's per second, scanned at 140 kVp, and these are the kernels. The BV56 is a sharper kernel with a higher iterative reconstruction, and we reconstructed at 70 keV after the fact. The heart rate was irregular with PAC, so really a patient that's very difficult to image. And as you may have guessed, this was challenging by all the other modalities to look for ischemia in this patient, given the body habitus. So how do we approach this? Obesity is a low flux state because of soft tissue attenuation, where every photon counts. So this increases noise and reduces the signal to noise. And photon counting here can help by filtering noise by based on the electronic signature, if you want to call it that. And keep in mind, when you're deciding on which kernel to use, the sharper kernels have more noise. So this may be one instance where you may use a kernel that is not as sharp to offset the increased noise that you have with the soft tissue attenuation. So some tips for the obese patients when you're scanning an obese patient: increase contrast, dose and rate. Remember, you're trying to fill that coronary, displace the blood in the coronary with contrast. So you need a larger amount of contrast and probably at a faster rate. Consider a timing bolus. We use timing bolus routinely in our center and we're quite successful with our coronaries by doing that. Reconstruction of the lower KV will increase noise, but you can offset some of that to a large part with higher levels of iterative reconstruction. And choose the kernel and iterative reconstruction based on noise level and sharpness. That's something you have to see after doing a few patients, seeing what works best in your center. So moving on to heart rate. So this is a patient that we did at a heart rate of 100, between 100 and 113. Again, reconstructed with a sharper kernel with a QR of 4, and we did millisecond reconstruction. So what are some strategies you can use for higher heart rates? Obviously, try and bring their heart rate down. The slower the heart rate, the better off you are. We have a very structured protocol with beta blockers and evaderine if necessary. We do millisecond reconstructions because keep in mind, as your heart rate goes faster, diastole shrinks. So your systolic, in the systolic phases, that stays quite constant, even though diastole shortens. So imaging in systole using millisecond reconstructions and, if needed, multi-second reconstruction is a strategy to work around this limitation. So moving towards stents and calcified atherosclerotic plaque. So this is a paper looking at the advantages of a photon counting scanner compared to an EID scanner. So here you can see clearly the delineation of the stent, the struts, the lumen is much better when you have a better temporal resolution, high spatial resolution, and reduced beam hardening as a result, with a better delineation of these structures. And this allows for accurate assessment of in-stent restenosis and also for smaller branch vessels. The other point that I had mentioned earlier is that monoenergetic reconstructions allow you to bin different energy signatures. So you have a low energy bin from 25 to 75, which enhances the iodine, and you have a higher energy bin. And here you can see that it reduces the blooming at the of the calcium at the higher energy reconstructions. So this is a patient that we did, 57-year-old male, status post LAD stent. This was acquired in ultra high resolution mode with a BV sharp kernel and QRR of 3 and reconstructed at 80 kV. And you can clearly see here, you can see where the stent is, and you can see the calcified plaque, which was displaced after the stent was just deployed. And here in the short axis, you can see that the lumen there's really no in-stent restenosis. I did think there was a moderate lesion distal to the stent with this calcified plaque in the mid-LAD. So what are some tips you can for imaging stents? Higher dose and rate of contrast, just like the calcified lesions. Optimize heart rate. The slower your heart rate, the better off you're going to be. Ultra high resolution images at 0.2 millimeters definitely help. And scanning at a higher kVp will reduce blooming and enhance your ability to discriminate in-stent restenosis. Using a sharper kernel, as we did here, with a QRR of about 3 to 4, will help with the interpretation of the images, and reconstruct at 80 kV or higher. So this is what I was describing earlier. It's a monoenergetic reconstruction, preferentially suppressing calcium. And you can see here where there's blooming here and the calcium suppressed. And here you clearly see the lumen within the contrast. So for calcific lesions, this is a helpful tool if you want to use that in addition to the other strategies that I described. So I'm just going to briefly go about kernels. There are different kernels. You have a body kernel, a vascular kernel for vasculature, and then you just have a regular kernel. In this paper, there was no significant difference on image noise in the different kernels, but as we said before, increasing sharpness within the kernel increased noise. For the large part for blood vessels, the vascular or the BV kernel had a higher vessel sharpness. What does that look like? This is a patient that we did that was 295 pounds. And I just put this up here just to show you the differences with the different kernels. I just want you to focus on the plaque here in the RCA proximal. This is non-obstructive, of course, but just to underscore the how different differences in imaging or the different kernels highlight different features. So here you have a softer kernel with limited iterative reconstruction. And here you have a sharper kernel. You can see increased noise. And here an even sharper kernel, and we went up on the iterative reconstruction, so you can see the noise here is comparable. And this is a soft kernel. This is a QR kernel. It's a regular kernel, so you can see it appears softer. But in this kernel, we reconstructed a lower KEV, which makes the lumen more prominent. So you have to really look at these different kernels and decide based on a patient-to-patient basis which is the best kernel and which is the best iterative level of iterative reconstruction for the question you're trying to answer is. So moving on to radiation dose, there are multiple strategies here, including prospective scanning, step and shoot modes. There's also a high pitch for patients with a good heart rate, less than 65. There's a high pitch spiral acquisition that entirely, essentially acquires the entire scan during one heartbeat that can substantially reduce dose, which is an option. But keep in mind, this is a good mode for patients without arrhythmias and a slow heart rates. You can also construct decision trees that automate some of this based on heart rate, arrhythmia, irregularity, where the system will pick the appropriate phase of reconstruction for the patient. So this is a patient that we did a prospective sequential acquisition. You can see it's every alternate beat at a heart rate of 58, and the DLP here was 240/49 which is approximately 3.5 millisieverts. So just wanted to talk about renal insufficiency. This is a patient who had a low GFR of 28, needed a TAVR study. We did it with 50 cc's of dye, and here post we reconstructed at 40 kV, and you can see here that the contrast here is more than adequate to be able to delineate the lumen of the vessel, and for us to be able to contour the annulus for his TAVR. 45 kV provides the optimal trade-off between objective and subjective image quality in this publication here, in the second publication. So moving on to coronary CTA, I just want to go over how we use it as a roadmap. So the first really point is that you want to make sure that people who get to the cath lab actually need an intervention, and that people with non-obstructive disease don't get to the cath lab. This paper, this is data from Manish Patel's seminal paper in the New England Journal, shows that about 70% of patients getting to the cath lab with a coronary CTA had an obstructive lesion, compared to about 44% for all comers. These are large numbers, SPECT MPR of 302,000, for example, 302,000 patients. This paper that was published demonstrates that with photon counting, your ability to discriminate the degree of stenosis is substantially better, especially for calcified lesions, with 43% of patients that were reclassified to a lower CADRAS classification without a penalty in the dose or the amount of contrast. Now, keep in mind, Quantum, the UHR showed a higher agreement with invasive measurements than the EID detectors, which makes sense because calcium has always been challenging to interpret. So here's a patient that we did with a calcium score of over 6,000. We reconstructed with a BV50 sharper kernel, QR of 3 and 70 kVp. And you can see here that there was no obstructive disease in the proximal RCA and the mid RCA and the proximal circumflex and the mid circumflex. And the tips that you can use for these patients with a higher calcium score is to use a sharper kernel. Again, having a UHR, using UHR mode, because having a better resolution reduces the blooming, as does the higher KEV. And you want to optimize heart rate, reduce motion, optimize contrast rate and dose, as we described earlier. I always say it's a rule of 3. So high BMI, very high calcium score, high heart rate. When you start combining all of these, 2 or 3 of these, it becomes a much more challenging scan. So you should make your best effort to reduce the heart rate, make sure there's adequate contrast on board, and then also consider using a sharper kernel after the fact. Now, keep in mind that with the softer kernels, you have less noise. So if you have a very large BMI, it might be helpful to use a slightly softer, less sharp kernel to offset the increased noise. So how do we optimize views using 3D data sets? You can see here this patient has a complex, if you want to call it a quadrification of his vessels. And he has an LED lesion, which may be potentially significant. So laying out this lesion with using 3D data set and having that conversation with your interventionalist is very, very helpful, because knowledge of proximal lesions avoids deep cannulations, avoids a masking of the lesions, and avoids vessel foreshortening. This is also especially helpful for bifurcation lesions. It identifies side branches and defines a PCI strategy. So what about plaque? We know that the type of plaque is important. We also know that the morphology of the plaque is important, with eccentric lesions with the same diameter stenosis being more likely to impede flow, and as well as rough lesions, that those are more likely to impede flow. This paper showed that the microcalcifications and fibrous cap on UHR correlated with invasive OCT measurements. So the UHR mode is quite helpful in that regard to identify the type of plaque and the morphology of plaque. And this patient that we had, it's a 6-year-old male with chest pain, complex lesion, and high plaque burden. Again, scanned with UHR mode, 0.2 millimeters with, and reconstructed with a sharp kernel with higher iterative reconstruction. And by our read, we thought the patient had triple vessel disease, a mid-RCA lesion, an osteocircumflex lesion, and a mid-LAD lesion. And we call this severe CAD-RADS of 4 with multivessel coronary disease and near circumferential calcium in the LAD. The patient had a software was sent, this was sent to HeartFlow to look for hemodynamic significance, and there was a hemodynamically significant lesion determined in all 3 distributions with a value of less than 0.0. In addition, the patient had non-calcified and calcified plaque. The non-calcified plaque was 91% for age. Calcified plaque was 57% for age, with the total plaque volume that was 73% for age. So essentially now with CT, we've identified the location, the length of the lesion, we identified the type of plaque and the hemodynamic significance. It's a comprehensive package. So when they go to the cath lab, they're informed in terms of a strategy ahead of time, which is extremely helpful. This paper is the Pacific study, was 208 patients where all patients underwent SPECT, PET, CT, invasive angiography, and FFRCT. So the important point I'd like to make here is the most of the time when you failed FFRCT was due to motion, misalignment, noise, and calcium burden. All of these things can be addressed with the photon counting CT, or it's far less likely to be an issue with the photon counting CT. So image quality and the type of images are very, very important when you're trying to do these assessments. Our acceptance rate for HeartFlow in our center is 98% or higher because of the way we approach this. So the patient's diagnostic coronary angiography confirmed very good correlation with anatomic, showing triple vessel disease with severe disease in the LAD, with a DFR that was significant, severe stenosis in the circ and the RCA. The patient went on to have IVUS, and again, the fact that he had circumferential calcium is one of the reasons that the interventionalists may want to consider doing atherectomy prior to placing a stent. The patient had a very good result after the intervention. CT can be used to predict the success of PCI in chronic total occlusion. This particular score is called a J score, which predicts the difficulty with procedure time and success. So higher scores predict the use of a retrograde approach, and each factor is given us a score of 0 or 1. The factors that are looked at are blunt stump. Here you can see a little bit of a beak, which is favorable. Calcification, we see no calcification here. A lesion angle of greater than 45. Here, the lesion angle is less than 45. The occlusion length of greater than 20 millimeters. Here is less than 20 millimeters, and here is a prior attempt and a prior attempt. So here, the patient has actually a very favorable score for the CTO. We scanned this patient in UHR mode with a slice thickness of 0.2 millimeters, BV, a sharper kernel with a QIR of 4. It was a spiral acquisition between 60 to 80%, and a calcium score of 939. And we surmise that the presence of contrast in the distal RCA may have been secondary to brisk collaterals. Keep in mind that just because you see contrast distally doesn't mean that this is not a chronic total occlusion. The patient went on for invasive angiography. You can see here that the right is occluded, and you can see very brisk collaterals coming from the left, and the patient received a successful PCI to the RCA. So pre-bypass surgery, this is a large topic, but for the large part, CCTA can be very effective in visualizing the landing zone for distal surgical anastomoses, identifying intramyocardial coronary paths if they exist, coronary anomalies, CTOs, and also the patency of the REMA and the LEMA. Now, the syntax scores, which can be generated with CT and CT-FFR, can also be helpful in planning surgery. And in the post-bypass patients, it's helpful to evaluate the retrosternal anatomy and graft patency as well. This is a patient with an anomalous coronary artery that got grafted to the right, and you can clearly see the anastomotic area here, which is patent. Graft is patent, and there's no stenosis at the anastomotic area. So this is actually acquired at non-UHR mode because of the length of the amount of coverage that you need for bypass surgery, and a large field of view. So it was 0.4 millimeters of BV, a softer kernel of 44, and about 3 in terms of the iterative reconstruction. And then finally, this patient that we saw who came in with chest pain had a coronary CTA demonstrating calcified and non-calcified atherosclerotic plaque in the LAD. And this is actually a complex trifurcating lesion and there's also plaque in the left main without any obstructive disease in the circumflex and the RCA. So this is the patient's left main, and this is what I call CT IVUS, where a cross-sectional area of the left main seemed to be favorable. You can see non-calcified plaque and calcified plaque here. And by our assessment, CT pre-planning, we thought that there was a non-flow limiting stenosis likely in the left main, but with high-risk features, but a significant stenosis in the LAD. This is the patient's cardiac catheterization demonstrating a tight lesion of the proximal LAD with this complex trifurcating pattern. The RCA and the circumflex were without disease. So good correlation with CT. And this is the patient's IVUS, actually showing that, you know, the cross-sectional CT appearance of the vessel is duplicated with the IVUS images. In fact, I would argue that we see the vessel wall better with CT. And the luminal diameter, minimal luminal diameter of the left main was about 10 millimeters, which does not need intervention, but a luminal diameter of 3 millimeters in the LAD and a DFR that was positive, which was suggestive of significant disease in the LAD. So essentially confirming what we found with CT. The patient received a stent to the LAD and including the diagonal with an excellent result. And I would submit that the pre-PCI planning was extremely helpful here. In conclusion, photon counting CTs allow for coronary CTAs to be performed in most patients with diagnostic images. Coronary CTA can be an effective gatekeeper to the cardiac catheterization suite. A coronary CTA provides valuable information about plaque burden, anatomic information which can be used for procedural planning and intervention. And CT-FFR can be added to this anatomic information, which will help with the management strategy. And in addition to this, coronary CTAs can also be used for procedural planning for chronic total occlusions and coronary artery bypass surgery. Thank you.
Thank you so much, Dr. Noce and Dr. Jacob, for some very great perspectives on how your facilities have expanded access to care to your patients and your communities. We really appreciate the insights that you've shared with us during today's session. So we've got, unfortunately, Dr. Noce is unable to join us for the live Q&A. He's had to step away for some pressing clinical matters. But there's been a question that's been shared that would be directed to Dr. Noce, and I will endeavour to answer on his behalf. But the question was, I can see the value of dual source CT used in a community environment, but with today's current staff challenges, have you encountered any difficulty in operating such a complex system? And has the technology and the automation that you've discussed in your presentation translated into supporting your staff and resulted in any improvements or shortened exam times? So Dr. Noce talked about the Pro.Pulse having My Exam Companion and the clinical decision trees. And that is on users in powerful embedded artificial intelligence to guide workflow. And what that really does is really empowers and supports all the technologists, irrespective of their experience skill sets, to perform even advanced CT examinations such as coronary artery CT angiography with ease, but with consistency both in the running of the scanner, but also in the image quality and the standardization. And so that really supports both for the reader, ensuring that they've got that consistency and diagnostic confidence in the image quality. For the staff, that guided AI helps guide them through performing the examination. As part of bringing the SOMATOM Pro.Pulse to market, we took 16 technologists that had never used the user interface or in fact performed cardiac CT prior to this. And we asked them to perform a CT coronary angio exam. And 82% of those technologists were able to perform that examination with ease on first attempt. And when we deactivated all of the guided workflow that's part of My Exam Companion and the clinical decision trees, 81% of those technologists were unable to complete that examination. So that's really proven time and time again, and we have a white paper available if anybody would like us to share that with you about how the user interface supports technologists irrespective of their experience. There's also technology called a mobile workflow, which translates into being able to do a lot of concurrent activity by the patient's bedside. So the mobile workflow with the iPad and the fast 3D integrated camera also helps the technologist do a lot of the scan preparation and setup by the patient's bedside. So it translates to improved patient care, but it also translates to workflow efficiencies. The scanner has embedded post-processing, so we call it our zero-click post-processing, and that negates the need to have to move and do, volume rendered, coronal, sagittals, bone removal, vessel segmentation views, all of that advanced post-processing. It no longer needs to be done on a separate workstation. So the next question, I think, is directed more towards Dr. Jacob. When discussing the fast temporal resolution of these scanners, you've mentioned that higher heart rates are able to be visualized. Dr. Jacob, what heart rate are your staff targeting for cardiac CT angiography?
So that's a great question. It's as low as possible. So we're always shooting for 60, and we have quite an aggressive protocol for beta blockade. We also have a evadrabine if need be as part of our protocol, and IV beta blockade if need be. But sometimes it's just, even despite giving them a dose of beta blockers, it's not easy to get patients bring them down to the 60s, 50s or 60s. So our policy is as low as possible, but it's nice to have the flexibility to be able to image in systole should we have higher heart rates. So I have a couple of rules that rules of thumb, so to speak. I'd rather have a higher regular heart rate than a lower irregular heart rate, because that allows me more flexibility in terms of reconstructing the images. You can widen the padding, but I showed you a patient with a heart rate of about 100. And now keep in mind the images I'm shooting at that point, I'm shooting for diagnostic. I'm not shooting for beautiful images. If they're diagnostic, which they were, is really what I'm shooting for. So that's kind of the way I approach the heart rate issue. We always try and get the lowest heart rate possible. Prepping the patient with, and one point I'll make there is that PO beta blockade always works better than IV beta blockade. Evadrabine works well, but it takes a long time. So it's 2 hours. You have to wait for 2 hours before it kicks in. So these are, you've got to use all the tools in your armamentarium.
Yeah, I think that's important. I think the flexibility that dual source photon counting CT provides is just that, right? You have the ability to tackle any patient, as you've talked about in the process. I think recently there was a couple of really big studies in photon counting cardiac CT, one from St. Francis, where they did a population of about 8,000 consecutive patients on photon counting as well as conventional scanners. And they showed an impact similarly to what you were demonstrating here. What has the impact been from your perspective towards the next step in patient care pathway because of the better information from photon counting?
Yeah, that's also a great question. So my thought now is that we've evolved. I showed you the evolution of coronary CT from, slip ring technology all the way up to now, where my focus right now with the coronary CT is more PCI planning. And in order to do that, you need very detailed information. If I'm looking for landing zones, I showed you the CT IVUS, cross-sectional areas. Our acceptance rate. So if you remember the Pacific study, one of the biggest criteria for rejection from doing CT-FFR was motion. So our acceptance rate at our center is 98%. We just looked at our data recently. So I think the future, to answer your question simply, it's stenosis severity. And if the patient is very challenging, we're a referral center for about 7 or 8 hospitals, and sometimes we get very challenging patients. So we do with the tougher patients, the higher calcium scores, higher heart rates, and we don't cancel for calcium scores or heart rates. We try and get it down, but we scan everybody. But so number one, the first step would be diagnostic certainty, making sure that you call, they get to the cath lab appropriately. Number two is if you have adequate image quality, providing that additional nuanced information, plaque lesion, plaque length, bifurcation lesions, circumferential calcium, do you need shockwave? I've found that conversation and the dialogue is always appreciated by our colleagues. And then number 3 is post PCI. We are scanning stents now, so the ability to scan stents, and we're restricting ourselves to above 2.5 or above 3. We try and keep it to 3 centimeters or 3 millimeters or higher. So it's the whole spectrum of diagnostic certainty, PCI planning, and then post-PCI service. In order for stents especially, and high calcium scores, you need crisp image quality, because if it's little amount of motion, will reduce our diagnostic certainty. So with calcium and stents, I think the more variables you stack onto trying to interpret through, the tougher the less your diagnostic certainty is going to become. So heart rate, having image noise, scanning at low kV with blooming, and not having enough contrast, you stack all those together, you're not going to get a diagnostic study. So we've been quite happy with our results, even in these very challenging patients.
Yeah, I mean, you definitely showed some quite challenging obese patients, 6,000 plus calcium score. I mean, those were things that people didn't really dream of. Well, maybe they dreamed of it before, but couldn't make it a reality. Another question that we see here is asking about the costs. And obviously, with the introduction of new technology comes higher prices, and certainly photon counting CT scanners are more expensive. For those who have specific questions, please come to Siemens, and we're happy to put together quotes for you. But I think maybe it aligns more with another paper even that also came out in the last couple of weeks, I think from the group at the Medical University of South Carolina, demonstrating improved cost effectiveness because of all of the benefits that you have talked about. Have you done any initial explorations at Wellspan in terms of how it's changing efficiency for you there, or optimizing what you can do towards that end?
No, we haven't officially looked at the data, but I have some early data saying that our conversion, once somebody, so a few things. I'm going to step back. So our goal, my goal for the system was really to have, to serve the interests of the patient. So that's always first and foremost, so that people who get to the cath lab are actually there for, they actually need something done. I've done this long enough where, cath is very safe now. That's evolved tremendously, but there is a small risk of complications, which you really don't want somebody there that doesn't need to be there. So the first point is that without quoting an exact number, because the data, as I just looked at the data recently, but the number of people who end up in the cath lab based on an abnormal CT end up having something done at a very high percentage, much more than the published national averages. So I don't want to give you a number, but that diagnostic certainty adds to the fact that people who end up in the cath lab actually end up getting something they need. And then the other pieces of this, where the procedural planning, cath lab efficiency, knowing that you need a shockwave up front, availability of catheters, knowing it's a bifurcation lesion and you want to probably schedule that earlier. Those are sometimes harder to measure, but also valued by my colleagues. I think in my conversations when I've had a conversation with our interventionalists, I think the input has been appreciated.
I mean, I think that's great. I mean, again, upfront cost of technology may be higher, but the overall impact downstream seems to be more cost efficient to most of the practices that I'm talking about. And your evidence here, it seems to follow suit with that. Really appreciate, Dr. Jacob, all of your time. I really loved all the cases that both you and Dr. Noce showed. For this evening, we are out of time. So I want to thank everyone for attending the webinar today. Really appreciate it. And if you have any questions on access to care, photon counting CT, please reach out to Siemens Healthineers. Thank you very much.
Thank you all.
Thank you.
Thank you, Dr. Jacob.